My goals for today's talk is to really just increase your understanding and awareness of emotional health. I will talk about why emotional health is important. I'm going to provide some background information on the phases of emotional development in childhood and throughout the lifespan. And knowing about the developmental process will help you feel more equipped to manage and promote emotional health in your children. And finally, I'm going to share some practical skills on talking with your children and building that emotional well-being. We often interchange the terms mental health and emotional health. When we think about mental health, we look at it in terms of functioning. So I put up kind of just the differential definitions here. You can see that they're really similar. I think it's important to note some warning signs we look for if we're seeing a decline in mental health. And what we tend to look at is the impact on functioning. So are the concerns that are happening, are they impacting relationships? Are they impacting kiddos' academics, how they're doing in school? Is it impacting sleep? Is it impacting eating and feeding? Are there changes happening around there? And is it impacting health? So if we're seeing symptoms that are impacting those things, we start to get concerned. Those are our red flags. Emotional health is thought of as resilience or well-being, and parents can play a really important part in supporting and encouraging a child's mental health habits. Mental health disorders run in families, so if you as a parent suffer from anxiety, your child's going to be more likely to have anxiety too. However, that can be changed based on the environment. So like we just discussed before, emotional health is a part of global well-being. So similar to other areas of development, emotional development is a process, and there's a spectrum in which there can be delays and arrestment. So emotional development also requires support and does not happen without effort. So you have likely been hearing about emotional health or social emotional curriculums being taught much more in school, and maybe you've read some articles. And the reason you're hearing more about this is that educators are responding to the current research that has come out about the benefits of supporting emotional health. So we know children who receive quality emotion coaching and education on emotion develop these 5 skills. So self-awareness, social awareness, emotional regulation, responsible decision-making, and relationship building. And these 5 skills are known to be important in navigating stressors and for building resilience. Children who have these skills tend to have positive relationships with their families and their peers. And these skills are thought of to be protective, so that no matter what stressors come up, children with these skills are going to be much more resilient. And they're less likely to have significant mental health concerns as well. On the other hand, children who are not given this emotional guidance often struggle with mood. They'll struggle academically, physically, with their health, and behaviorally. And this makes sense if you think about it. So if you cannot, as a child, if you cannot notice, express, or manage your emotions, it's incredibly difficult to focus on school and make friends and work on a team. I'm going to talk a little bit about how emotional development goes across the lifespan in some young children, because it's a little bit different talking to a 3-year-old about emotions than it is talking to a tween or a teen. It's also important to support emotional health and have really realistic expectations. So obviously you're going to expect something different from a toddler than you would expect from your teen too. And for really young children, we think about them going from really simple emotional development to more complex emotions. So a newborn baby is going to have really primal emotional responses, and then as they're growing into school age, they're going to have more complex, more range of emotions. One thing that's really important when you're thinking about emotional development is it helps you to have more realistic expectations. So if you expect too much from a child as far as their emotion coping goes, you're going to be disappointed and frustrated. And if you're disappointed and frustrated with your child's emotional expression, they're going to start to associate shame and anxiety with their emotions. So we know that that can hurt development. On the other hand, if you expect too little from your child, so if you don't think they have capacity to cope with things, children can learn unhealthy behaviors instead of developing effective skills. So this is why it's so important to be aware of the different emotional stages and how your child, where your child is at. A good example of this is that we know that 2-year-olds have tantrums, right? We know that they have tantrums. And knowing that this is a typical part of development is so helpful in how you're able to respond to them whenever they're struggling. In elementary age, we think of kids really going through an emotional process of figuring out empathy. And part of how they do this is they really tend to focus on what's right and wrong and learning a lot about that. And so I think about this developmental phase that they're trying to learn to regulate emotions and figure out when things are gray, right? So things can be really black and white for kids when they're young, and then they start to see that there's ranges of gray about things, and helping them to manage that uncertainty and to manage their own values about things being right and wrong. Escalations and big emotions can be really difficult for adults. So when you have an elementary age kiddo and they're really struggling and having a big emotional reaction, a lot of times adults can feel really uncomfortable with that. So we also need to remember that children experience complex emotions, and a lot of times they haven't yet figured out a healthy versus unhealthy way to express those emotions. So as children learn to recognize their own emotions, we can help them recognize other emotions as well. And that will help at this elementary age to help build that empathy and compassion for others. The goal with the skills for parents is that helping children understand that frustrations happen, but what matters most is how you handle them. And we tend to teach this with a lot of positive reinforcement and praise. For tweens, the emotional development, they are trying to navigate those social relationships. They are trying to figure out what's going to help them be popular and liked by their peers. And so one thing that is really helpful for parents to remember during this kind of developmental phase is that, as trivial as they may seem, the child is entitled to their emotions. And even though it feels unreasonable that you've told them 20 times that they needed to turn the iPad off, instead of pointing out how absurd it is for them to be angry when you've warned them that screen time is coming to an end, we recommend that you validate that they're mad. I get it, you're mad. You still wanted to play more and you can't. So pointing out what they're feeling at that time can be really helpful. All right, let's move to the skills. Here are 5 strategies that I think are really helpful and global across the developmental spans that can be really important for helping your kids. And I'm going to go through each of these 5 basic skills and provide some examples. And again, parents can really nurture a child's mental health by building some other basics, building a close relationship with them, providing structure and boundaries, fostering independence, encouraging good social connections, and teaching healthy habits by modeling positive behavior. Now I'll go through some details. So how to talk to your kids about emotions. So first off, it's important to just kind of make it a habit to check in with your child with how they're feeling. As most of you know, if you say, how are you feeling? You're going to get a 1-word response. Fine, good. You're not going to get much information. So learning to ask open-ended questions and approaching it with curiosity can be really helpful. You're going to ask your kids specific questions about their school day. How are you feeling before this test? How did it make you feel to be left out of the game at recess? What was that like for you? This can help them learn to recognize their emotions, and then you can brainstorm ways to cope. You can also ask your child about experiences during the school day with how their classmates would feel. So we've talked about like elementary age, they're trying to learn empathy, so doing that quite a bit. One thing we often don't talk about regarding emotions is about the timing of it. And I think that's really important. What we tend to do is that when we see our children really escalated and frustrated, we try to take that time to make it a teaching moment. And when we're escalated and upset, we're not receptive to learning. So it's often important to check in after kids have calmed down and talk about what it is that made them upset. What were they thinking that drove those feelings? So we want to kind of observe, we want to acknowledge, we want to label. So it looks like you were really worried about having that needle stick today. I could tell you were worried because you were kind of trembling, you were talking really fast, and just kind of talking about those things. And then really validating. Validating is super important. You may not agree with why they're feeling the way they're feeling, and you may not understand why they're feeling the way they're feeling, but naming it, saying what it is, and accepting that that emotion is their experience is super important. And it's going to help them to be able to talk with you more.
Stacy, we have 10 minutes, so I'm
okay.
What you want to move forward.
I'll go through the next ones really quick.
Okay.
How about that? Okay. So creating opportunities for independence is super important. You're going to want to give them lots of different experiences and allow them to fail sometimes. That also builds resilience. That's really important. Also, building a toolkit of coping strategies is really important. And all kids are different, and it's something that takes practice. So some kids will want to talk about emotions, others will want to go for a run. And figuring out what works for your kiddo and encouraging them to practice and explore what those things are takes some time, but having about 3 to 6 things that they can do to manage those big waves of emotions are super important. And then this is like the least popular one that no parent wants to hear, but you have to model managing emotions in a healthy way. And this takes some reflection and some courage, because we may not always take care of ourselves in the way that we would want our child to take care of ourselves. So being really reflective on how do I manage really big stressors? Am I handling this in a healthy way? And also, not hiding things from your child. It's okay to say, you know what, that doctor's appointment was, my heart was racing and I was really worried about what we were going to talk about today. And talking about like what you did to feel better. Like I took a few deep breaths, I made sure I played some good jazz music on the drive over. Here's some things I did to kind of help me feel better. So labeling those and explaining that for your children are super important. And then the basics too, lifestyle, self-care activities, those things are also protective. So making sure we're living a well-balanced life, we're getting exercise, we're getting adequate sleep, we're eating healthy, we're balancing our media consumption, we're doing things like mindfulness that help build us up and make us feel better.
Stacy, there's a question about what about mental health when prednisone is on a high dose and kids are really unable at times to manage their feelings? Do you have any suggestions for that?
Yeah, I think you just acknowledge that this medication is making it hard to do, and you talk about what could you do. So do you need to do something that's even more tactile for you? So sometimes taking a warm shower or doing something that will kind of shift you a little bit out of your mind and more into your body. So really thinking about like, yes, this medication is making it so hard. You feel so out of control. You feel so escalated, but there's usually something that you can identify that would make it better in the moment, because just sitting there and thinking about it is not going to help, right? The restlessness, that tension that kids feel when they're on that medication is super intense. And I think acknowledging that and validating it is still one of the best strategies. Great question. That's so hard. And then I don't want to take up other people's time, but happy to answer any questions as we get back to our panel. So thank you for listening.
There's another question, which I think we can address as we go along. So I'd love to hear from Megan, and then I'll come back, Mandrake, to your question.
Just working on my screen share here. If you want to answer a question while I do that, it's fine with me.
Okay, so here's the question to Stacy. If you practice all these things daily and always have, but the child has a difficult time identifying or expressing and or communicating, so they might be on the autism spectrum somewhat, and so they don't always know what is going on internally, being neurodiverse, how do you teach a child to communicate these things if they use an AAC for communication part-time? And if that's too complex a question for right now, maybe you can put that your thoughts into the chat.
No, that's a great question. So a lot of times having things be more visual can be really helpful. So sometimes kids on the spectrum will do better. There's like the mood meter system. So they talk about a color rather than a feeling. Sometimes you have visual cues that have simple faces that kids can look at and cards. There's lots of creative ways for kiddos that aren't really verbal, that don't have that insight, but they can usually pick out a picture or a color and start communicating in kind of some other ways.
Okay.
Great question.
If you have some more thoughts, I'd love for you to just type it into the chat. And Megan, are you ready to go? Or do you want me to share, or are you okay?
Yeah, it's odd. It's not sharing correctly. Are you seeing my screen?
I do.
What do you see?
I see the first slide, and then I see on the side, slides on the side as well.
Okay.
Yeah, that's great. Okay, now you got it.
Okay. And you are seeing the presenter view, correct?
Yeah. This is Megan.
Now you see the whole screen?
Okay.
All right. Hi, everyone. Thank you to CureJM so much for asking me to speak today. I am a pediatric rheumatologist at the University of Colorado. Juvenile myositis is my main rheumatic disease of interest, and I am going to talk to you today about a physician's perspective about talking about mental health within the scope of your visits to your clinic. Let's see. Ooh, okay.
Are you still having struggles with that?
Here we go.
Okay.
So I thought I might just give you a little bit of information about what doctors learn in medical school. What we learn about mental health is quite broad. So in our first 2 years of medical school, we learn things like what we just learned from Stacy about the developmental stages of humans at various ages. And we learn how to take a history about a patient's mental health. We then move into clinical rotation. So all medical students, regardless of what specialty they are going to go into, do a rotation within pediatrics that mostly focuses on physical health. And we also do a rotation in psychiatry where we learn about mental health. We learn about things like how depression and anxiety are defined, the risks of developing mental illness like schizophrenia in the young adolescent age. We learn the importance of taking a family history, but we might not have any face-to-face experience with pediatric or adolescent patients during our psychiatry rotation. If we're going to become a pediatric rheumatologist, then we move into a 3-year residency in pediatrics. And this is where we get our training about all different aspects of caring for patients with various pediatric conditions. So we rotate through the hospital and we take care of kids who are hospitalized. We take care of kids in a clinic, outpatient setting, kids in a general pediatrics clinic. We do a rotation with our adolescent medicine doctors, and that's where we learn a lot about focusing on mental health and taking a history of the patient's social life, not just their medical history, which I'll come back to. We may be able to do a rotation in psychiatry that's more of an elective. It's not a required rotation. Doing a rotation in pediatric rheumatology is also an elective and not required for all people going through pediatrics residency. The social history exam that we learn to do is called the HEADS exam. I'm going to have the next slide about that, but HEADS is an acronym that is spelled out here on the right side of the screen. We also learn a little bit in residency about these things that are called ACEs, adverse childhood experiences. And having more ACEs can increase patients' risk for chronic health problems, mental illness, substance abuse, and even autoimmune conditions like juvenile arthritis and myositis. After our 3 years in residency, then we do a fellowship where we spend 3 years learning pediatric rheumatology. So we care for kids inpatient and within the clinic. The emphasis on mental health training that we get in our fellowship really depends on the program that we're at and how interested faculty members are in emphasizing the importance of mental health. And we learn how to do something called a patient global assessment, and I'll talk about slides with that in a minute. So this slide I'm not going to read through, but it just gives you some examples of when a provider is taking a history from a teenager about their life, some of the questions that we can ask using this HEADS model. And I thought you might be interested in reading those questions and thinking about how you, if you're a patient, how you would answer, or how you think your kid might answer. These are QR codes that you can flash your camera on. This is an article about the HEADS psychosocial interview. And then also a website that is created by the American Board of Pediatrics, which certifies physicians to become pediatricians or rheumatologists. And they have a project focusing on how we can best support our patients and families with regards to mental, emotional health and resilience. This is a slide about adverse childhood experiences, ACEs. So the ACEs that are tallied in this quiz that you can take through this article here are abuse, physical, emotional, or sexual abuse, neglect, including physical and emotional neglect, And then household dysfunction, so having a family member with mental illness, someone who has been incarcerated, in a household where the mother has been treated violently, substance abuse within the household, and divorce. None of these have to do with the child's own physical health, but these are experiences they could have that can make it harder for them for their both mental and physical health moving forward. So what are trainees, our doctors who are becoming pediatric rheumatologists, what should they be taught about mental health in children and adolescents with myositis and or other conditions? Well, we need to learn that at diagnosis, it's important for us to assess for pre-existing depression and anxiety. We need to ask about their mental health, things like ACEs. We also need to acknowledge that there are stresses and uncertainties related to getting a diagnosis. Many of you experienced an odyssey getting your diagnosis. It may have taken a long time. And then just the stress of receiving a diagnosis of chronic illness is quite difficult for patients and caregivers. The other things that we learn are the effects of juvenile myositis and the treatment. Autoimmune conditions, including JM, can affect the central nervous system, which can make a patient more prone to having pain and even mental health concerns. Medications like prednisone have definite effects on the central nervous system, emotions, and behavior. And then the effects of the stressors on the immune system, almost a vice versa. So being stressed and having psychosocial stress can really affect the way the immune system works. We also learned that stresses after diagnosis differ depending on these things here, how severe a patient's JM is, if they've had damage related to the myositis, changes in physical appearance, age, coping skills within the patient and family's resources. And then, of course, we learn a lot about the ongoing stresses of having a chronic disease after diagnosis, including all of these things that you see here. And I'm sure many of you can add more to this list. But our patients certainly go through a lot of stress related to having a diagnosis of JM. I just wanted to make you familiar with something called global assessments. And I have some examples on the next slide. So physicians make global assessments of our patients, including how active we think their muscle disease is, their skin diseases, things outside muscle and skin that can happen with JM. And we also make an assessment on how active we feel their JM is, and then how much damage is going on related to the dermatomyositis. And these scores are used when we calculate how active a patient's disease is, and we also use them in figuring response to treatment. So patients and parents also have global assessment scores that we should be asking in our clinical visits. And I will show you in the next couple of slides, there's a few different ways that a patient or parent can give a global assessment. And there's also some problems inherently associated with these. So one of the assessments that is used in CARA studies is something called the Patient or Parent Global Activity Assessment. So the question is, considering all the ways that myositis affects you or your child, rate the overall activity of your disease today by placing a mark on the line below. Sometimes there's numbers, and this is considered 0, no evidence of activity, and a 10 or the worst is considered extremely active or severe disease activity. What can be confusing is some studies refer to this as the patient or parent evaluation of a child's overall well-being, even though what it's asking about is active inflammation in the body. Other global scores that you might come across are one that asks about your overall well-being of you or your child as related to their disease. This one I got from the internet about juvenile arthritis, but we just substitute different diagnoses. This can be confusing because sometimes this question, it might not be clear if we're asking about how you're doing in general or how you're doing related to your rheumatic disease. So there's a few different ways to ask this question. And then I'm going to skip through this slide, but it talks about patient-reported outcome measures. There are other questionnaires and instruments that your rheumatology practice might administer asking about how patients are doing in terms of things like fatigue and pain, and just their overall functioning in life. And here's some examples, if you're in the care registry, that might look familiar, some questions that are asked of the patients if they're 8 or over or older, or the parent. There's another severity scale that is not currently being used in practice, but it's available on the internet, and I thought you would find it interesting. It's asking about how methotrexate is tolerated and whether children have stomach aches, nausea, vomiting, or behavioral complaints. So there are various barriers that we as providers face when we're dealing with mental health in the office, and potential solutions that I've listed on the next few slides. So one is that as providers, we feel responsible for our patients' mental health, but we might have few referrals or support within our system to offer. And I listed some of these barriers over here on the left. Some potential solutions is that as a provider, I know it's my responsibility to help with my patient's mental health care and to ask, but I can also engage other providers who have unique skill sets to help. Most practices don't have a mental health provider, but pediatricians' offices often do, and they can be helpful. Another barrier is that not only physicians and care can feel discomfort with the topics of mental health, but patients and caregivers might as well. So when people are upset and worried about, when we as a provider think about asking about mental health, we really don't want to bring up a lot of things that might upset a family or a patient in the visit. But over on this side, I have some solutions about things that providers can do and that parents and families can do as well. A third limitation is time. So we have variable time in clinic, and we have a lot of medical concerns that we need to speak about, as well as mental health concerns. It also is challenging sometimes to have a parent leave the room and come back if we're under a time constraint. And if there are severe concerns, we might have to refer a patient to the emergency department. So some potential solutions is that we can have separate visits to talk about mental health or transition to adult care, and we can utilize telehealth for these things. We can also utilize some of our other team members. There are privacy concerns when we're interviewing a patient alone, and I listed some of those concerns here on the left. Things that we can do is make sure that as providers, we are understanding what rights to privacy a child and adolescent has, and parents should also understand what rights their kids have regarding privacy. And then there are also some safety concerns if a patient tells us that they have self-harm thoughts or suicidal ideation, or if they reveal that they're being abused or neglected. Things that we can do as providers to help with those things is to ensure that we have a system within our clinic if something like that needs to happen. And some of us worry that, oh, if I send this patient to the emergency room because they need psychiatric help, the family might lose their trust in me or not want to come back to see me. And I think it's important for us to explain to families that our primary concern is the health and the care of their child, even if we have to do things that are hard, like referring them to mental health providers. And then finally, I just wanted to say that it's important for us to acknowledge family members' mental health, as well as our patients in the clinic. So I make sure that I talk to family members about how they are doing, not just their child. And then the last slide, I just have some tips for talking to your provider about your child's mental health. So they're in 3 areas. One is if your provider doesn't ask about things, you can tell them yourself. So make sure you know about your child's ACEs, your family's mental health history. Think about the HEADS questions and the global scores. And you can ask to privately speak to your provider if you don't want to talk to your child. You could call ahead to clinic or send a message beforehand, and the provider can arrange it. And it's also really important to give your child time to speak to the provider alone. As a parent, you should be proactive about stepping out of the room and giving your child that space. And then in the yellow box, if you go back and look at some of the slides about global scores, you can ask your child about these scores before the visit. If the provider isn't asking about these things, you can provide that information. That's the last I have. I'm sorry I went over, but I know that Suzanne is taping this, and so you'll be able to go back and read through the slides in more detail.
So one quick question before we move on, is methotrexate another treatment that can mess with emotions?
I'm going to be
Certainly can. And
sorry, Anna, did you want
go
to?
ahead, Anna.
Well, I have that in my thing, so I will definitely be speaking to it. But Megan, give your spiel too.
Okay.
Sure. Probably not as much from a chemical standpoint in terms of changing your emotions, but the stress around methotrexate and how awful it can make kids feel really can cause a lot of emotional distress.
Thank you, Megan.
You're welcome.
Of time, I'm going to move on, and I'm going to share this screen. Can everybody see this? Can everybody see this? Okay, Stacy says yes. Annie, do you want to? I'm going to introduce
Yes.
Annie Mitchell is a longtime JM parent. She's been parenting for, her child was diagnosed about 15 years ago. She's trained as a special education teacher, and she has she's been on the JM board and JM board and research committee, and she has lots of experience dealing with mental health issues. So take it away. Oh wait, this is the wrong one. Sorry, folks.
Well, just while you're getting that up, because I was going to keep it on that title slide for a second. I really thank you, Suzanne, for doing this, and appreciated so much what Dr. Curran and what Stacy had shared. I just wanted to take a moment to acknowledge that, everyone who's gathered here today is just because of the dedication that all of you have to the JM kids in our lives. And what we're discussing here tonight, just like what others have shared before me, really is applicable to JM siblings and to the family unit, because we know that those suffering with JM do not suffer alone. It affects the entire family. So just a disclaimer as what was shared, that I'm not a mental health professional. You've heard from a wonderful mental health professional as well as a medical professional, but dealing with emotional and mental health issues can feel like a steep learning curve as a parent. And our family has been experienced the steep learning curve. So we know it may be scary at times. And if you're like me, at times you might feel powerless or so lacking in your knowledge of how to support someone that you love. So just to take a moment right now and just breathe, take a deep breath. You're here tonight and you are not alone as you go through this. So as what has been said before, the first thing I just wanted to, as a tip, is to listen. So much in the biggest part of talking to kids is really listening, actively listening in our society, and as parents and caregivers, we have so much on our plate. We juggle so much. We have endless lists and tasks that we are doing. We are multitaskers extraordinaire. And so it really is, at least for me, has to be a very active choice that when I'm listening, it's not thinking about what I'm going to say or how I'm going to try and solve the problem. It's just listening. And I loved what Stacy said about validating as well. And I would also add to this that it's actively listening and listen actively. Kids move a lot. That comes from my education background. And depending upon their age, learning style, how they best process and communicate, adding movement or having some kind of activity where you are moving together or doing something kinesthetically together in arts and craft can really further open discussions when they're talking. Acknowledging the courage that it takes to disclose feelings and being vulnerable. It's also important. It can be something simple as, I know this is really hard to talk about, isn't it? I'm so glad you're talking about it with me. Or it could be something like, thank you so much for trusting me with this. Building the basis with all of the smaller ways that you're building trust with, having them that safe space to share feelings. When it comes time to disclose, more times where this feelings might be more powerful or scary at times, then they have the courage to come to you. So as you know, allowing your child to have feelings and having that safe space to discuss them. Stacy did a great job of discussing this as well, so I won't spend that much time on this. But I would just want to share that, you know, we did have an experience of one of our kids was on a medication that he had a side effect that included very distressing and dark thoughts. And because we had given him that trust was built, and he had that safe space where he felt safe coming to us in order to share that. And then we could share with his doctors what was going on. And they knew to say, yes, that's a side effect. Let's take these next steps. But so it's continuing to have that times when you're building the listening, the trust, that the spaces where they, with the emotions that they're feeling, they feel as though they're able to come to you. So again, I'm just emphasizing listening. In this, I put it again here because sometimes it's hard in the silences or what we feel is awkward pauses to be able to sit in that. As our kids become tweens or teens, it can be sometimes difficult. But if you're willing to just wait and be able to sit with them and listen, allow them time to process. Summarizing your children's feelings, using that kind of reflection and making sure in those times that you're not always making assumptions about what you're understanding about what they're saying. We use this a lot in our family of saying, okay, what I'm hearing you say is this. Is that what you're saying? Or this is what I'm hearing. Or, oh, that sounds like you felt, you know, I'm hearing you say, and then they can have a time to say, that's not what I'm saying at all. You're not hearing me. And then we can continue to go, okay, I guess I didn't understand what you were saying. Can you try and say it again? Because we all have different ways that as we're trying to communicate, as I'm trying to listen, I'm trying to meet them where they're at and how they're communicating, and making sure that what they're saying, I really want to be able to hear them, not just listen to them. modeling how to talk about feelings. That was well covered. So we'll go into the next slide. So this was just some things that we've done in our family at different ages, which was some tips and tricks. Definitely breathing, taking a breath, allowing for everyone in the family, parents and caregivers. You can actually practice deep breathing, but also that represents giving yourself grace. We're not going to always get it right. There are times that we're all going to have hard days. So take a breath, give yourself grace, and try again. Just keep trying again, trying to do our best as parents and caregivers, just like they're trying to do, best job they can as kids. To know that, we remind our kids that they are not alone, that, we might not have answers, but to remind them that they're not alone in this. We're going to figure this out together. And that's one of the things that I also really so enjoy and love about CareJM is the community, and that as parents and caregivers, as a community, you are not alone in this. Everyone's very familiar with time out, but we really like to try time in activities together. So it could be any way in which you're trying to find something to do to continue to build that connection and trust with one another. One example was that when my college-age daughter, who did not go to college too far away, she needed additional emotional support during one period of time. And so several times a week, I would drive to where she was going to school, and we'd just take a walk together. And in all kinds of weather, we walked in the snow, we walked in the rain, we walked on sunny days, but it was just a way that we had this time. There was movement, we got to talk together, and it just was this, we called it, so I refer to it as this kind of time and activity together, where we could check in with one another.
Move you
okay,
a little.
Sure.
Like, stay on this slide or move to the next one?
So you can move on. I was just going to say also the similar things when, preschoolers, you don't always go for walks, but you might get down on the floor and play with them or do arts and crafts with them. Another great thing is there's wonderful books you can get at the library that all have to do with surrounded with feelings. And then on the last page, this is my last slide. With tweens and teens, adolescents, being willing to listen when they're willing to talk. So maybe they need time to just cool off and process. Maybe they're night owls, like so many of them are. But understanding communication styles as well. So maybe they aren't a talker, maybe they like to do something and are more movement oriented, and then that's how they open up. And then so as the validating was definitely brought up, and I think everything else was well covered. So thank you for
Annie.
Allowing me to share.
Thank you. Any quick questions before we move on? I know we're running late. I'm hoping that everybody can hang in there for another 10-15 minutes. And I'm going to share this next screen. Nope, that wasn't it. So let me find it. This is Anna Ramsey. And Anna, I'm going to let you introduce yourself and tell us a little bit about yourself.
Okay. Well, you can skip to the second slide then.
Okay.
So I am Anna Ramsey, and I am now 24. I'm currently getting my master's of social work from a Cal State school, and so I'm not technically a healthcare provider yet, but I hope to be a therapist at some point in the near future. So a little bit about my story. I started experiencing fatigue and some muscle pain around the age of 13, and like most of us, I had a very difficult time getting diagnosed. I was told that I was experiencing growing pains for many years, but I have not grown in a long time. So at the age of 15, I developed over the course of the summer, my health went from bad to worse, and I ended up going to a adult rheumatologist, and he diagnosed me. I am now 24. I am still fully medicated, but I have gotten myself down to the lowest dose of all of my medications, which is the farthest I've ever come towards remission. I also did 6 years of Rituxan. I included my medications because sometimes people are curious about that. Oh, it didn't change the slide for you for the next one. I changed it. Oh well, I'll figure it out. Okay. Next slide, please. Okay, well, I had changed it a little, so this might be a little out of order, but all of the information is basically the same. So what I'm about to go into isn't all necessarily advice, but a lot of these are points that I want to kind of point out that have played a huge role in my mental health during my journey with JDM. Keep in mind, as I was diagnosed at 15, a lot of this advice is going to be more geared towards teens and young adults. But I think it's good to have in mind, and I think it can kind of play into everyone's story. So I'm not trying to freak anyone out with some of this, but I think it is really important just to be aware of what some of your kids might be thinking about. So the first one that I actually want to go over is white coat syndrome. I absolutely love my rheumatologist and her whole team. I have a lot of fun when I'm in the office with them, but at the same time, I get very anxious before every appointment. And because of that, my blood pressure is always like stupid high. And so I usually can't sleep the night before an appointment, and I have a really hard time getting an IV put in. My veins have all shriveled up. And so that is something that I'll think about for a couple of days before an appointment. It's just getting my blood drawn. So even if it's a simple appointment, it kind of gets hyped up in my head. So I usually can't sleep the night before, and it is hard not to associate every appointment with kind of the trauma of some past appointments, even if it is just a basic appointment. So it is really important to remember that your child is most likely, no matter what their exact story with JDM is, they probably have some medical trauma. And no matter how much they like their doctor or how simple of an appointment it may be, being in a doctor's office, no matter the doctor, is still a reminder that they are sick and that this is their life. And so that alone can cause acting up or kind of behavioral responses to things. So I am next going to talk about loneliness. Because JDM is so rare, it is really hard not to feel extremely lonely. After I was diagnosed, I made it, I think it took me like 8 months before I found Cure JM, and my first conference made a huge difference because I made a friend who was just like me. So I have created a whole network of other young adults who may actually be very different than me, but we all understand each other on this deeper level because of our JDM. I have people I can text on treatment days, or if I have a flare, or just to rant, or even now I'm at the point where they're just my friends. So we don't even have to be talking about JDM, but I know that they understand what I'm going through. And I think it's really important to have people that you can rant to and that will understand you. I think we all love a good rant. So something that kind of goes hand in hand with loneliness is relationships. This is pretty specific to my age range at the time of my diagnosis. And many of your kids may not be there, but as a 15, 16, 17-year-old, specifically for me, girl, trying to find out what meds worked and going through a lot of flares, the idea of like liking boys and dating was a huge source of my anxiety. And I know that's probably something you don't necessarily want to think about, but I think that's a huge part of any teenager's like kind of mindset, maybe potentially. And so when you throw in prednisone and feeling like a round little ball and like, you know, you have all these medications, it's hard not to feel like a burden. So this is something that I still deal with today. I'm now much older, but I've always been scared that like weakness would be unattractive, or that going through my treatments would be a burden on whoever my partner is. So I think this just adds an additional stress to like being a teenager. Like these are things that are already stressors as a teenager, and then everything's kind of just piled on top. So I think it's really important to just be patient, because your kid probably has a lot more going on in their mind than they want to talk to you about. So the next point is kind of, someone mentioned this in the comments before, but taking meds. Another thing that I think parents might not think about is it's not just the physical side effects that our meds have on us, but it really just the act of taking your meds has a really strong effect on mental health. So everyone knows about the side effects of prednisone. They make you feel yucky. Methotrexate makes you feel nauseous. But taking your meds every day is just, it's a daily reminder that you are still sick and that you are different. So like most of my friends weren't taking meds every day. In my personal opinion, this is especially true of shots and infusions. I gave up the methotrexate shot when I was in college and swapped it for the pills because it was too difficult every week on my emotional health. And so I did IVIG for 2 years, and I've switched over to sub-Q because, as I said, my veins are yucky. And I still find this being an issue. So I do my sub-Q every week. And for the most part, it's fine. My boyfriend is actually very supportive and makes it a lot easy. But every couple of weeks, I do have a little meltdown over it because it is that reminder, and it is like a constant part of my life. That I've had to get used to. So I think it's the fear of not knowing if or when it will stop. For a lot of kids, it does, but it's hard not to kind of think like, is this just my life for now? And that leads me into grieving. So I've kind of alluded to grieving a couple times already, but I think this is a really important category. Your child, whether they know it or not, is going to grieve their old healthy life. So things are just different after this diagnosis, and you will build a new normal, but you kind of have to give them time to adjust, because there's a lot of things that they won't be able to do anymore, and a lot of things that they kind of expected for their future, depending on when they were diagnosed, that might be taken off the table for a little while. So we usually think of grieving in terms of losing someone, but in this instance, they are losing themselves in a way, or at least they might think so initially. I personally actually believe that having JDM has built me into the person I am today, and I'm very grateful for this, but it took me a long time to kind of get to that point. And I also think it is really, really, really important to remember that you as parents are also grieving your life. This is not what you expected for your child. And now your life is filled with doctor's appointments and whatever else comes with it. So I think it is just as important for you to take the time to grieve your life and take care of yourself, because your mental health can have a serious effect on your child's. Oh, you can see my rash coming out. That's really nice to show off. Okay, so I'm next going to talk about therapy. I think therapy is super, super important. And I was lucky to come from a family of therapists, but I know that most people do not necessarily have the same situation, and a lot of people don't have experience with therapy or maybe believe in it. But my mother put me into therapy the second I was diagnosed, and I'm still with the same therapist to this day. And I'm so grateful for her. I think, you know, parents really want their kids to be able to talk to them about this stuff. And a lot of the time they're just not going to want to. And so it's really important to have kind of a third party person who's removed from your life, who you can talk to and rant to. And they can just give you a different opinion that you don't maybe want to hear from your parents. So I think it is also important for the parents to possibly be in therapy. I think a chronic illness, especially a juvenile one, affects everyone, and you cannot support your kids if you are not getting the support that you yourself need. So the last thing I will talk about is peer support. As much as I have loved therapy, I think the biggest support I have found is from my peers. I made my friends through Cure JM, actually, at most of the conferences. Here's a picture. A lot of them are younger than me, and that has not stopped my friendships. I've become friends with Grace, Annie's daughter, who is my age, thankfully. But it's like age has not been a boundary. These kids, I'm talking to like 5 of them right now. And when I went to college, of course, there weren't really kids with JDM at my university, but I found a support group for chronically ill people on campus. And I created lifelong friends through that group as well. I think it's really important to have people who understand what you're going through. They don't have to have JDM, but a lot of people with chronic illnesses have a lot of similarities. So just finding people who you can identify with is huge. And then last but not least, I think letting your kids be in charge of some aspect of their life. JDM takes away control over your own body. So giving them some sort of control is really important. If that's, you know, making sure they know how to take their own meds, so they're in control of their own meds, or in a doctor's appointment, giving them control and letting them speak and not feel like you're speaking for them and the doctor's only speaking to you as a parent. I think any sense of control over their bodies is really important. So that autonomy. Yeah, that's my presentation.
Thank you, Anna.